It's time for another 3-question warm-up. Let's get going. What is the classic electrocardiogram finding in pericarditis? So you're going to see diffuse ST segment elevation and PR depression. Next question. A patient is unable to inspire completely due to pain during palpation of the right upper quadrant. What is the sign and what is the diagnosis? So this is Murphy's sign, and the diagnosis is going to be acute cholecystitis. Next, which vasopressor matches each of the following statements? Theoretically causes renal vasodilation, that's dopamine. High doses optimize the alpha-1 vasoconstriction, that's going to be epinephrine and dopamine. Antidiuretic hormone is going to be vasopressin. Best choice for anaphylactic shock, that's going to be epinephrine. Best choice for septic shock, that's going to be norepinephrine because it causes vasoconstriction. Best choice for cardiogenic shock, dobutamine. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Welcome to the musculoskeletal section of the course, which encompasses rheumatology and a little orthopedics and some bone diseases like osteoporosis and bone tumors. Now we're going to start with some hardcore rheumatology like lupus and polymyalgia rheumatica. Most of these rheumatologic diseases are very important for your test. Each of these diseases in this section is at least 3 stars, and some are 4 stars. This is very commonly tested stuff. Now first up is lupus, which is a chronic inflammatory autoimmune disease that can affect all sorts of organ systems, as we're going to see. Like many autoimmune diseases, it's more common in women. It's more common in blacks than in whites in the U.S., although interestingly it's pretty uncommon among blacks in Africa. It's also more common in Asians and Latinas than in whites. Now black women tend to be affected the earliest, between 15 and 45 years of age. So think about lupus whenever they give you a young black woman with a confusing constellation of findings. Now, for some reason, whites tend to get lupus at an older age than blacks do, in their 40s and 50s. Even black men get lupus later than black women do. So young black women, middle-aged everybody else. Now, as I said, the clinical presentation can be all over the place. It tends to look very different from one patient to the next. Now, rather than list every possible problem that lupus can cause, I've listed the American College of Rheumatology's 11 official diagnostic criteria for SLE. So to diagnose lupus, the patient needs to have at least 4 of these. Not necessarily all at once, but 4 of these over time. Now the first 4 are skin findings that you can see with lupus. They can have a malar rash, that butterfly rash across the nose and the cheeks. They could also have a discoid rash, which are these discrete raised lesions on the face or the scalp, which may cause some scarring. This is what the singer Seal has on his face, scars left over from discoid lupus. So that may help you remember what these look like. They can have photosensitivity, and they can have oral ulcers. These are painless oral ulcers, very important. These aren't painful ulcers like aphthous ulcers. These are painless oral ulcers. Remember that. Then moving on from the cutaneous manifestations, these patients can have arthritis, which is a non-erosive, non-destructive arthritis in at least 2 joints. It's inflammatory arthritis, but it's typically non-erosive, which is different from osteoarthritis or rheumatoid arthritis. They can have various types of serositis, which is inflammation of the serosa, such as pericarditis or pleuritis or a pleural effusion. They can have renal disorders, which is very important. Lupus nephritis and renal failure are major causes of death in lupus patients. Neurologic disorders include things like seizures and psychosis and peripheral neuropathies. Hematologic disorders include hemolytic anemia, leukopenia, lymphopenia, and thrombocytopenia. And then the last 2 are sometimes called immunologic criteria. A positive ANA is one of the criteria. ANA is a pretty nonspecific test, and although ANA is one of the diagnostic criteria, you don't have to have a positive ANA to make the diagnosis of lupus, but it is one of the criteria. And practically speaking, we're talking about significantly positive ANA, like a titer of 1 to 160 or 1 to 320. An ANA titer of 1 to 2 or 1 to 4 is somewhat common and very nonspecific. Lots of other things can elevate the ANA besides lupus. So just because you have a positive ANA, that doesn't mean you have lupus. But we often use ANA as a screening test for lupus because the vast majority of lupus patients do have a high ANA. But if you don't have a positive ANA, the likelihood of lupus is very low. And then the American College of Rheumatology calls the last one immunologic disorders, specifically if the patient has positive anti-double-stranded DNA antibodies or anti-Smith antibodies or anti-phospholipid antibodies. You don't need all 3. Any one of them is enough to check this box. And having all 3 doesn't give you 3 positive criteria. That's just 1 criteria altogether. So if your patient has 4 of these 11 criteria, that's diagnostic for SLE. Now, a couple of words about these labs. Anti-double-stranded DNA antibodies and anti-Smith antibodies are pretty specific for SLE. They aren't terribly sensitive, but they are pretty specific. You should also be aware that lupus patients typically have low complement C3 and C4 levels, which contributes to immunodeficiency and risk of severe infections. And patients with drug-induced lupus will typically have anti-histone antibodies. We'll come back to that in a moment. It's tricky to make generalities about treating a disease as variable as lupus, but avoidance of sun exposure is important because of the photosensitivity. Now, that doesn't mean these patients have to hide in a dark room, but it does mean that they should wear UV protection diligently. Patients with active lupus are commonly treated with hydroxychloroquine. NSAIDs and steroids are used as anti-inflammatories, and then immunosuppressants are sometimes used as well, depending on whether or not there's renal disease. But for the most part, you're going to be asked to recognize and diagnose lupus on step 2, not to treat it. You should also know about some common complications. Lupus anticoagulant antibodies, including anticardiolipin antibodies and antiphospholipid antibodies, cause hypercoagulability. And then these patients are also immunocompromised, so they have an increased risk of infections, and that contributes to the morbidity and mortality. These patients also have an increased risk of cardiovascular disease and kidney failure, as we discussed. I also want to go back briefly to drug-induced lupus. The question in the study guide says, what drugs are most commonly associated with drug-induced lupus? These are drugs that cause a lupus-like syndrome. Now, you can remember them with the mnemonic SHIP, which stands for sulfonamides, and especially sulfasalazine, although any sulfa drug could potentially do it, hydralazine, isoniazid, phenytoin, and procainamide. And what type of antibodies are associated with drug-induced lupus? Antihistone antibodies. Make sure you know that. Now, you can see antihistone antibodies with regular lupus as well. So antihistone antibodies are not always associated with just drug-induced lupus. But for the purposes of your test, if you see antihistone antibodies, think about drug-induced lupus. The other thing about drug-induced lupus is that it's reversible. If you stop the drug, the lupus symptoms are going to go away. Next, let's talk about PMR. Not PBR, not PMS. It's PMR, which stands for polymyalgia rheumatica. The major risk factor or association is giant cell arteritis or temporal arteritis. We talked about giant cell arteritis in the video on vasculitis, headache, jaw claudication, possible blindness. And we said that most of these patients are elderly, especially elderly women. Despite the name polymyalgia, PMR doesn't actually cause muscle tenderness. It causes joint pain and joint stiffness, especially pain and stiffness in the shoulders and then possibly the neck and the hips. But there's no muscle weakness, but lots of joint pain and stiffness. Now, do you remember the main lab abnormality in patients with giant cell arteritis? It was elevated ESR, erythrocyte sedimentation rate. And the same is true for PMR. The SED rate will usually be very elevated, and CRP will be elevated too. A lot of these patients also have anemia. And these patients have negative serologic markers, negative ANA, negative rheumatoid factor. This is one of the few diseases we're going to discuss in this video that has negative serologic markers. If you did an MRI or a PET scan, you would see evidence of synovial inflammation. But we don't really do imaging for PMR typically. It's not necessary. The treatment is similar to giant cell arteritis also, glucocorticoids like prednisone. But unlike giant cell arteritis, you don't need high-dose prednisone, just low-dose prednisone, like 15 to 20 milligrams a day. Some rheumatologists say that PMR patients feel better when you just give them a whiff of steroids, even after just a day or two. And then after a couple of months, you can start to slowly taper them off the steroids. But if you have a patient you think has PMR and you give them steroids and they don't get better, it's not PMR. Something else is going on. Next, let's discuss polymyositis and dermatomyositis. Polymyositis sounds a bit like polymyalgia, but this is a form of myositis, or muscle inflammation. And dermatomyositis is basically the same thing, except that you add some skin findings. Patients with either of these disorders will have progressive, symmetric weakness of the proximal limb muscles, the hip flexors, the shoulders, the deltoids. So they start having trouble climbing stairs, or they have trouble raising their hands above their head to comb their hair in the morning. It tends to affect large muscle groups, proximal muscles, because there's simply more muscle tissue to be diseased. These patients may have some muscle soreness and tenderness, but for the most part, this is a disease of weakness, not pain. Contrast that with PMR, which causes shoulder and hip pain rather than weakness. Now, with dermatomyositis, there are several possible skin manifestations. It might be a malar rash like we saw with lupus. It might be a purple heliotrope rash on the eyelids. It might be Gottron's papules, which are reddish, scaly papules on the knuckles, possibly on the elbows and the knees. It might be something called mechanic hands, where the fingers become rough and cracked. Here you see those changes on the foot. This can even look dirty sometimes, like you've been working on a car. It might be something called shawl sign, where the rash is over the shoulders, like a shawl draped over the shoulders. Or a V sign, where it's on the anterior chest in a V shape, like a V-neck shirt. But if you see any of those plus muscle weakness, think about dermatomyositis. Now, both dermatomyositis and polymyositis will have several notable lab findings. There's active muscle inflammation, so muscle enzymes like CK, ALT, AST, and aldolase are going to spill out of those damaged muscle cells into the blood. ANA is positive in about 80% of patients, and anti-Jo1 antibodies may be positive. These are also called anti-synthetase antibodies. But anti-Jo1 antibodies are a classic finding. An electromyograph, or EMG, will help you distinguish between muscle pathology and nerve pathology, but muscle biopsy is the key to confirming the diagnosis. You're going to see muscle fiber degeneration and inflammatory cells. The treatment is high-dose glucocorticoids for 4 to 6 weeks, followed by a gradual taper. And in addition to steroids, we sometimes give methotrexate or azathioprine to reduce the length of time that the steroids are needed. You should also remember that polymyositis and dermatomyositis are associated with an increased risk of malignancy. About 15% of patients with dermatomyositis and 10% of polymyositis patients will either be diagnosed with malignancy at the same time as their diagnosis, or they're going to be found to have malignancy sometime down the road. And what malignancies are we talking about? Well, the same malignancies that are found in the general population, things like breast cancer, prostate cancer, lung cancer, colorectal cancer. You're just slightly more likely to get cancer if you have polymyositis or dermatomyositis. Another disorder that sounds a bit like polymyalgia is fibromyalgia. And the symptoms are similar in that it causes a lot of joint and muscle pain, but this is more widespread pain. You can think of fibromyalgia as an increased sensitivity to pain, kind of like the pain thresholds have been reset so that things that shouldn't be particularly painful now are painful. It's been somewhat controversial over the years as to whether or not fibromyalgia really exists at all, because there's no obvious anatomic or pathologic cause for the pain, and there aren't any specific radiologic or lab abnormalities associated with this. Fibromyalgia is more common in women, especially women ages 20 to 50 or so. We don't know exactly what causes fibromyalgia, but lots of patients with inflammatory rheumatologic diseases like rheumatoid arthritis or lupus will also have fibromyalgia. These patients tend to be more responsive to treatment than those who only have fibromyalgia. And it's also associated with depression and with poorly understood diseases like irritable bowel syndrome. Now, like I said, fibromyalgia patients present with widespread muscle and joint pain. Everything hurts, pretty much all the time. But there's no joint swelling or joint inflammation on physical exam. On physical exam, you may find multiple tender trigger points. There are specific points on the body, 9 on each side of the body, that are tender when you mash on them. Now, the old criteria required at least 11 of those 18 points to be tender, but more recently, they've removed a specific number requirement. Besides pain, these patients almost always complain of severe fatigue and sleep disturbance. At least 30% of these patients also have depression or anxiety. And they can also have cognitive disturbances. These patients often don't feel very mentally sharp, kind of like they're in a fog. The labs and x-rays will all be normal. That's one of the reasons this diagnosis is so controversial. There aren't any objective findings. You don't actually need labs to make the diagnosis, but you need them to rule out other diagnoses and to reassure the patient. And that's a big part of the treatment, reassurance. You need to reassure the patient that you've made the correct diagnosis, that they don't have lupus or some mystery disease or some form of crippling arthritis. This is a relatively benign disease, although it does decrease the quality of life. Walking and stretching exercises can be very beneficial, and so can good sleep hygiene, making sure these patients get their sleep disturbance under control. And you have to address their depression or anxiety. The pharmacological treatment options include acetaminophen and NSAIDs for analgesia. We try to avoid opioids because with these patients they're going to have chronic pain. There's a lot of potential for abuse. We sometimes use pregabalin, which is an anti-epileptic drug, or SNRIs like duloxetine, milnacipran, or even venlafaxine. And then since sleep disturbance is such a big problem for these patients, sometimes we need sleep aids. Next up is systemic sclerosis, which was formerly known as scleroderma. Now this is a disorder of excess collagen deposition, not just in the skin, but potentially throughout the body. That's why the name was changed from scleroderma to systemic sclerosis. There are two main types of systemic sclerosis: diffuse cutaneous systemic sclerosis and limited cutaneous systemic sclerosis. Diffuse cutaneous systemic sclerosis is characterized by diffuse, widespread sclerosis involving both the skin and the visceral organs like the kidneys, the lung, and the heart. And this progresses rapidly, and it tends to involve the visceral organs fairly early. The sclerosis and scarring of the skin makes the skin tight and sometimes kind of shiny, and you don't see a lot of wrinkles. And the tightening of the skin on the fingers can cause contractions of the fingers and sometimes ulcers on the fingers. So these patients might have trouble extending their fingers and possibly have some difficulty with hand grip too. This is associated with antibodies against DNA topoisomerase 1. Now, another name for these antibodies is anti-SCL70 antibodies. SCL is for scleroderma or sclerosis. But be familiar with both of those names, anti-DNA topoisomerase 1 antibodies and anti-SCL70. You can also see anti-RNA polymerase antibodies, but the anti-SCL70 antibodies are far more common. The other major form of systemic sclerosis is called limited cutaneous systemic sclerosis, which means that the skin involvement is limited to the hands and maybe a little bit on the face and neck. There's less visceral involvement and it progresses less rapidly. This one can be associated with something called CREST syndrome, which stands for calcinosis cutis, or calcification of the deep layers of the skin, often in the fingers. Raynaud phenomenon can be seen in diffuse cutaneous systemic sclerosis also, and other disorders, like we saw it in thromboangiitis obliterans or Berger disease. The E in CREST is for esophageal dysmotility due to sclerosis of the lower esophageal sphincter, which leads to reflux or dysphagia. So there's less visceral involvement, but this can affect the GI tract, specifically the esophagus. Sclerodactyly is fibrosis of the skin on the fingers, and then the T in CREST is for telangiectasias, which are located on the lips, the face, and the hands. And limited cutaneous systemic sclerosis is associated with anti-centromere antibodies. You might remember C for centromere and C for CREST. The treatment is mainly supportive, depending on what organs are involved and how severe the involvement is. If you have a patient with esophageal disease and GERD, you give PPIs. If you have a patient with Raynaud phenomenon, you give a calcium channel blocker to prevent some of the vasospasm. If you have a patient with sclerosis of the kidneys causing hypertension or renal failure, you give ACE inhibitors. And then for patients with severe skin sclerosis, we can give methotrexate or mycophenolate or possibly cyclophosphamide. But again, I don't think you're likely to be tested on treating this for step 2. Next is Sjogren's syndrome, which is an inflammatory autoimmune disorder that affects exocrine glands, especially the salivary glands and the lacrimal glands. This could occur as an isolated primary disease, or it can occur as secondary Sjogren's syndrome associated with other autoimmune disorders like rheumatoid arthritis or lupus. Clinically, Sjogren's syndrome often presents with a triad of dry eyes, called xerophthalmia, dry mouth, or xerostomia, and arthritis. Around 50% of patients with Sjogren's syndrome will have arthralgias and non-deforming arthritis. The eye symptoms may include dryness, conjunctivitis, and a sensation of sand in the eyes. And the dry mouth may also present as dysphagia, or difficulty swallowing. Whenever a patient tells you he has trouble swallowing, you need to be sure to ask for more information about what exactly he means by that. Because if he has a dry mouth, you're not going to be worried about an esophageal stricture or esophageal cancer or something like that. So figure out exactly what the patient means when they say, I have trouble swallowing. These patients can also have enlargement of the parotid glands and increased risk of dental caries because the normal alkaline environment in the mouth has been disrupted. These patients may also complain of nasal dryness or vaginal dryness. These dryness symptoms are sometimes called sicca symptoms. When you hear sicca, think of desiccation. Now, there's no single test that's perfectly diagnostic for Sjogren's syndrome, so you have to base the diagnosis on the clinical picture plus serologies. These patients can have autoantibodies against the antigens SSA and SSB. SS is for Sjogren's syndrome, and the other names for these antibodies are anti-Rho and anti-La. You can also sometimes see a positive rheumatoid factor in this disease as well, even in patients without rheumatoid arthritis. The treatment is supportive symptomatic care. You use artificial tears for dry eyes, or possibly cyclosporin eye drops. You use muscarinic agonists like pilocarpine or cevimeline for dry mouth, and arthritis may require hydroxychloroquine or methotrexate. And finally, I want to say a very brief word about something called mixed connective tissue disease. Now, this is the lowest yield of all of these, which is why I put it last. Well, I'm not going to say very much about it. As the name implies, mixed connective tissue disease has a lot of overlap with the findings associated with lupus, polymyositis, and systemic sclerosis. So these patients may start with Raynaud phenomenon, have some swollen fingers and arthritis, and then later they get inflammatory myopathy and muscle weakness like polymyositis. Then they get pleuritis and pleural effusion or pulmonary fibrosis and so on. There's a lot of overlap, and they just don't fit neatly into any of the other diseases we've discussed. But the lab test that really unifies mixed connective tissue disease as a single unique disorder is the presence of anti-U1 ribonucleoprotein antibodies, anti-U1 RNP antibodies. That's the big take-home point. They almost have to give you that in order to make the diagnosis obvious. Now we're ready for the end of session quiz. So pause the video and work through those questions, then we'll go over the answers together. First question. A 65-year-old African-American woman is evaluated for weakness. She was previously an active person but now has weakness in her lower extremities. On exam, both legs are equally weak. She also has a rash on the chest. So what labs would help establish the diagnosis? So you should be thinking about dermatomyositis as a diagnosis. So the first labs you order are aldolase, CK, AST and ALT, and maybe an LDH, all looking for evidence of muscle inflammation. You could also order ANA and anti-Jo1 antibodies. Next, a 67-year-old woman complains of bilateral shoulder and hip pain severe enough to cause difficulty in getting out of bed. ESR is markedly elevated. What's the treatment for this condition? So this is polymyalgia rheumatica. So the treatment would be low-dose steroids. The SED rate here is very important. Without that high SED rate, you might be thinking about something like fibromyalgia. Next, which serious disease must you look out for in patients with polymyalgia rheumatica? That's giant cell arteritis, which is serious because it can lead to blindness. Next, which rheumatologic disease matches each of the following descriptions? So these are really high yield, so make sure you can identify all of these. Proximal muscle weakness and facial rash is dermatomyositis. Pain and stiffness in the hips and the shoulders is classic for polymyalgia rheumatica. Muscle pain and tenderness in multiple distinct locations is fibromyalgia. And arthritis plus oral ulcers plus proteinuria suggests lupus or SLE. The last question, which 4 skin findings are included among the diagnostic criteria for SLE? The malar rash, discoid rash, photosensitivity, and painless oral ulcers. That's it for now. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. What is the most sensitive and specific lab test for the diagnosis of chronic pancreatitis? So that's going to be a low fecal elastase level. Next, what is the anatomic structure marking the boundary between the duodenum and the jejunum? So the answer is going to be the ligament of Treitz. Now the significance of this structure is that it separates an upper from a lower GI bleed. Next, what is the tumor marker for hepatocellular carcinoma? So this is going to be AFP or alpha fetoprotein. All right, that's it for the warm-up. Let's get to the lecture now.
In this video, we're going to discuss several different kinds of arthritis, including osteoarthritis and rheumatoid arthritis, both of which are very high yield for step 2, plus psoriatic arthritis and ankylosing spondylitis, which is a form of arthritis that affects the spine. So let's start with osteoarthritis, or OA, which is the most common form of arthritis. OA is a 3 or 4 star topic for step 2. It's also sometimes called degenerative joint disease because it represents degeneration of the joint, or wear and tear on the joint, which kind of gradually wears down the articular cartilage. The main risk factors for OA are aging and obesity. You know that older people are always complaining about joint pains and arthritis, and OA is the most common cause of this. And obesity is a big risk factor because when you carry around a lot of weight, you're causing more strain on those weight-bearing joints like the knees and the hips, more wear and tear. And a third risk factor is joint injury. Trauma to a joint or repetitive stress from heavy labor will increase the likelihood of getting arthritis in that joint later on. OA is a non-inflammatory arthritis that affects the hips, the knees, the ankles, the hands and fingers, and even the spine. It causes joint pain, especially joint pain that worsens with use and gets better with rest. Now that's an important clue to help you distinguish osteoarthritis from rheumatoid arthritis. A common presentation of OA is knee pain at the end of the day after you've been walking around all day, or pain in the hands after you've been working with your hands. But then when you rest, it gradually gets better. Another important clue to help distinguish OA from rheumatoid arthritis is that OA does not cause systemic symptoms. It's purely a joint disease. The physical exam is a big part of this diagnosis, especially in the hands. So this can be asymmetrical arthritis, so you get arthritis kind of here and there, but not necessarily symmetrically. And you can see bony enlargement of the DIP joints and the PIP joints. These knobby joints in the DIPs are called Abraham's nodes, and the PIPs are called Bouchard's nodes. And unlike rheumatoid arthritis, these swollen joints aren't boggy or squishy or inflamed when you mash on them. This is bony enlargement. Now on X-ray, you're going to see bony growths called osteophytes, as well as some narrowing of the joint space. So here you can see that the MCP joints have nice open joint spaces, but in the DIPs and PIPs, the joint spaces are really narrowed. This looks like bone-on-bone arthritis, which indicates really severe arthritis. You can see the same kind of thing on X-rays of the knees: osteophytes, joint space narrowing, and bone-on-bone arthritis. Labs aren't really necessary to make the diagnosis, but to contrast what we're going to see in rheumatoid arthritis, the SED rate is normal because this is non-inflammatory, and there are no abnormal serologies or autoantibodies with this. The treatment includes modifying activity to prevent joint overuse and to provide for periods of rest. Remember, this pain is worse with use and it gets better with rest. Weight loss can help if the patient's overweight. Even with arthritis of the hands, obesity increases the risk of OA in the hands by about 3-fold, so weight loss is a good idea. We use acetaminophen, NSAIDs, or celecoxib for analgesia. Now, what's the maximum daily dose of acetaminophen? 4 grams per day. We try to avoid opioids if possible, but sometimes we can't. Another option is to inject the joint with glucocorticoids to reduce local inflammation. This can temporarily relieve a lot of joint pain. It's a little more practical in big joints like the knee rather than in little joints like the fingers. And for OA of the knee, we can also inject hyaluronic acid into the joint space. Hyaluronic acid is an important component of synovial fluid, so putting that into the joint space can help lubricate the joint. And then the last resort is joint replacement, especially with that severe bone-on-bone arthritis. If you have an obese patient that can't walk because of severe osteoarthritis of the knee, she's going to really have a hard time losing weight because it hurts too much to exercise. So it's just a downward spiral of weight gain and worsening osteoarthritis. So replacing the knees can really help correct that process. Now let's contrast osteoarthritis with rheumatoid arthritis, or RA. RA is an autoimmune disease, a kind of type 3 hypersensitivity in which immune complexes are deposited in the tissue. This causes joint inflammation and what we call pannus formation, synovial hypertrophy, and development of granulation tissue on the articular cartilage. Like many autoimmune diseases, RA is more common in women, and it's frequently associated with HLA-DR4. RA causes a chronic inflammatory arthritis that first affects the hands and the wrists, and then later the large joints. Another big clue to distinguish RA from OA is that there's morning stiffness. There's pain and stiffness in the morning, but that gets better with use. Or if the patient sits and rests for several hours, they'll kind of stiffen up. So it's worse with rest, and then it improves with use. And that's called the gel phenomenon. RA can also cause some systemic problems like subcutaneous nodules, called rheumatoid nodules, or pleuritis, pericarditis, or scleritis, inflammation of the sclera. On physical exam, you're going to see swelling of the MCPs and the PIPs. Remember, this is an inflammatory arthritis, so the joints tend to be swollen and warm and a little squishy. They give a little bit when you squeeze them. They're not hard and bony like the joints in osteoarthritis. And it's the MCPs and the PIPs rather than the PIPs and DIPs like we saw with OA. You can also see some ulnar deviation, where the fingers deviate toward the ulna, away from the thumb. These patients can also develop swan neck deformities and boutonniere deformities. Let's talk about these for just a second because students tend to get tripped up on them. Both of these deformities have flexion at one IP joint and extension at the other IP joint, but which is which? Let me explain. Boutonniere is French for buttonhole. With a boutonniere deformity, what happens is the extensor tendon on the back of the finger splits and the PIP joint kind of pokes through like a button going through a buttonhole. Make sense? So if you can remember that, you can remember with the boutonniere deformity, you have flexion at the PIP joint, and that joint is poking through that buttonhole in the extensor tendon. So flexion at the PIP and extension at the DIP. That's the boutonniere deformity. Then swan neck deformity is just the opposite. You have extension at the PIP and flexion at the DIP. So between the location of the joint involvement and the gel phenomenon and these specific hand deformities and the systemic inflammatory findings, you ought to be able to diagnose OA versus RA. Definitely be able to do that. Another diagnostic clue is that labs are useful in diagnosing RA. For starters, SED rate and CRP are often elevated, but that's pretty nonspecific. A little more useful are rheumatoid factor, or RF, and anti-citrullinated protein antibody. Rheumatoid factor is an anti-IgG antibody that's positive in about 75% of RA patients at some point in the course of the disease. But that means that at least 25% of patients with RA will be negative for rheumatoid factor. And rheumatoid factor can be low positive in lots of other diseases. So rheumatoid factor is good, but it's not perfect. Anti-citrullonated protein antibody, or ACPA, is another antibody that you can test for, which is actually more specific for rheumatoid arthritis. The next study guide question is about treating rheumatoid arthritis. The first-line treatments for RA are disease-modifying anti-rheumatic drugs, or DMARDs. So for mild RA, you could use hydroxychloroquine, which is a quinine derivative, or sulfasalazine, which is a salicylate, or some rheumatologists like to start with methotrexate. We use methotrexate in very, very low doses, as little as 5 or 10 milligrams once a week in milder cases of RA. And then we can titrate up to higher doses as needed to put the RA into remission. For moderate RA, you'd probably just start with methotrexate. A lot of guidelines recommend holding off on methotrexate in patients with mild RA, but again, lots of rheumatologists start with methotrexate. In patients who can't tolerate methotrexate or who don't respond to it, you might use one of the TNF-alpha inhibitors. The TNF-alpha inhibitors are etanercept, adalimumab, golimumab, certolizumab, and infliximab. TNF-alpha is a cytokine that induces the immune system response. And the TNF-alpha inhibitors are drugs that bind to TNF-alpha and prevent it from activating the immune system. All of them except etanercept end in the suffix mab, which tells you that they're monoclonal antibodies. They're antibodies against TNF-alpha that bind to circulating TNF-alpha and take it out of commission. Etanercept's a little bit different. Etanercept's actually a protein that's been engineered to look just like the TNF-alpha receptor, so that TNF-alpha thinks the drug is the receptor and it binds to it. So etanercept acts as a decoy receptor that binds up all the TNF-alpha in the body. It's also important to remember that since these TNF-alpha inhibitors are inhibiting the immune system, they carry an increased risk of infection, especially reactivation of latent TB. So in general, we check a PPD before we start any of these drugs. Then the next bullet is a drug called leflunomide, which inhibits the immune system by inhibiting proliferation of lymphocytes. There's also a drug called anakinra, who I thought was the Jedi who became Darth Vader. But actually, anakinra is an IL-1 receptor antagonist, which has anti-inflammatory effects. And make note, steroids and NSAIDs are used as adjunct therapies, but not as the main therapy. Patients with rheumatoid arthritis need to be treated with DMARDs. Next up is psoriatic arthritis, which can sometimes mimic rheumatoid arthritis. Psoriatic arthritis is a type of arthritis that develops in patients with psoriasis. Now, psoriasis is going to be covered in the dermatology section, but just as a quick review, psoriasis causes sharply demarcated, red, raised plaques that are kind of covered with this silvery scale. And these most commonly occur on the scalp, the elbows, and the knees. Now, up to 30% of psoriasis patients will develop psoriatic arthritis. So you can have psoriasis without any arthritis, or you can have psoriatic arthritis without any psoriasis, although that's less common, or you can have both psoriasis on the skin and the arthritis. And usually the skin lesions develop first. Psoriatic arthritis can cause several different types of arthritis. It can cause an asymmetrical inflammatory arthritis that typically involves the DIP joints, or it can cause a more symmetrical arthritis that looks a lot like rheumatoid arthritis. Sometimes it causes severe mutilating arthritis called arthritis mutilans, and sometimes it causes arthritis of the spine or spondyloarthritis. It can cause dactylitis, which is inflammation and swelling of the fingers, sometimes called sausage fingers. And notice the pitting and dystrophy of the nails, which goes along with psoriatic arthritis. It goes along with psoriasis in general. This may also be associated with anterior uveitis, inflammation of the iris and the ciliary bodies in the eye, or possibly conjunctivitis. Now, if the clinical presentation isn't enough to give you the diagnosis, labs may be helpful. These patients are typically positive for HLA-B27. They're usually negative for rheumatoid factor and ANA. Psoriatic arthritis is known as one of the seronegative spondyloarthropathies. It's seronegative. The serologies are negative. And then x-rays of the fingers may show bony erosions and what we call pencil-in-cup deformity. First-line treatment consists of NSAIDs or celecoxib. And then if that doesn't work, you can try things like methotrexate, leflunomide, or the TNF-alpha inhibitors. But again, what's the first-line treatment? NSAIDs or celecoxib. Another one of the seronegative spondyloarthropathies is called ankylosing spondylitis. So spondylitis means inflammation of the spine. So ankylosing spondylitis is a chronic inflammatory disease of the spine and sacroiliac joints. Anytime you see sacroiliitis or inflammation of the sacroiliac joint on your exam, one of the first things you should think about is ankylosing spondylitis. Ankylosis indicates fusion of the joints. So you can see fusion of the SI joints, or fusion between the intervertebral discs, or sometimes fusion in the facet joints. You can actually see what we call a bamboo spine on X-ray. So instead of the normal light vertebrae and then dark intervertebral discs in between, you can see calcification and mineralization of the bone outlining the intervertebral discs. So the spine ends up looking like a stick of bamboo. This is a disease that affects men 2 or 3 times more frequently than it affects women, especially young men in their 20s and 30s. And it affects more whites than blacks or Latinos. It tends to cause low back pain that's worse with inactivity and improves with exercise. So these patients may have a lot of back pain at night and when they first get up in the morning, and then it gets better after they go for a run or something. These patients will often have reduced spine mobility, even to the point where they're permanently hunched over in advanced disease. You may have heard of the Schober test, where you locate the patient's posterior superior iliac spine and you make a mark at that level on the patient's back. And then you measure 10 centimeters above that mark and make another mark on the patient's back. Then you have the patient bend over and touch his toes, and you remeasure the distance between those 2 marks. Now normally that distance will increase by at least 2 centimeters when the patient bends over, often as much as 4 to 6 centimeters. But if there's restriction of lumbar spine flexion, that distance may not increase much. In addition to the low back problems, these patients may also have hip and shoulder pain, and they can develop anterior uveitis, which causes eye pain, blurred vision, and photophobia. And they may have cardiovascular disease, especially aortic regurgitation and conduction disturbances. Now I mentioned that this is another seronegative spondyloarthropathy, so the labs are similar to psoriatic arthritis. Positive HLA-B27 in about 90% of patients, and then negative serologies like rheumatoid factor and ANA. Then X-rays of the pelvis may show some sacroiliitis and SI joint fusion, and X-ray of the lumbar spine may show that bamboo spine. Treatment includes physical therapy and exercise, NSAIDs or celecoxib, not just on an as-needed PRN basis, but scheduled continuous NSAIDs. That tends to work better for these patients. And then if that isn't enough, we often use the TNF-alpha inhibitors for seronegative spondyloarthropathies. That's a good association to keep in the back of your mind. Now, real quick, a student shared a fun mnemonic about ankylosing spondylitis, which goes like this. Cross my heart, hope to die, stick some bamboo in my eye. The cross my heart reminds you of the cardiac manifestations like aortic regurgitation. The bamboo reminds you of the bamboo spine, and in my eye reminds you of anterior uveitis. And we've talked about 2 of the seronegative spondyloarthropathies, but just for completeness, let me mention that there are 4 of them altogether, and they share some features like arthritis and positive HLA-B27 and anterior uveitis. And the mnemonic for all 4 of these is PAIR. P is for psoriatic arthritis, A is for ankylosing spondylitis, I is for the arthritis that can be associated with inflammatory bowel disease, Crohn's disease, and ulcerative colitis. And then the R is for reactive arthritis, or the old name is Reiter syndrome. That's the one that causes conjunctivitis or uveitis, urethritis, and arthritis. Can't see, can't pee, can't climb a tree. I want to finish up by briefly reviewing the serological markers for the various rheumatologic diseases we've covered, both in this video and in the last video. Let's do this with a whiteboard review. Over here on the left, I've listed all the diseases we've covered in these 2 videos, and we're going to match up all the immunological markers on the right. So starting with ankylosing spondylitis, that's one of the seronegative spondyloarthropathies, which means it's associated with HLA-B27. Now that's not an antibody, that's one of the genes for the major histocompatibility complex. But again, that's an important immunological marker for this disease. Diffuse cutaneous systemic sclerosis is associated with anti-SCL70 antibodies. And another name for that is anti-DNA topoisomerase antibody. Now, fibromyalgia is associated with none of these antibodies. That's an important point for fibromyalgia. It has no abnormalities on the labs or X-rays. Limited cutaneous systemic sclerosis is associated with anti-centromere antibodies. Remember, this is a disease where you can see CREST syndrome, and you can remember C for CREST and C for centromere. Mixed connective tissue disease is associated with anti-U1-RNP antibodies. Osteoarthritis is another disease where you have none of these immunological markers. Rheumatoid arthritis is associated with rheumatoid factor. That one's pretty easy. Remember, rheumatoid factor is actually an anti-IgG antibody. And then rheumatoid arthritis is also associated with anti-citrullinated peptide antibodies, or ACPA. Polymyalgia rheumatica is our other disease that is associated with none of these autoantibodies. But what's the lab that is abnormal in PMR? SED rate. SED rate is going to be very high in PMR patients. That's an easy way to make the diagnosis. Polymyositis and dermatomyositis are associated with anti-Jo1 antibodies, which is also called anti-synthetase antibodies. And then this can also be associated with ANA, so remember that. Psoriatic arthritis is our other seronegative spondyloarthropathy, so that's associated with HLA-B27. Sjogren's syndrome is associated with anti-Rho antibodies, which are also called anti-SSA. And then you can also see anti-LA antibodies, which are also called anti-SSB. And then lupus, you know it's associated with ANA, that's our common screening test. Anti-double-stranded DNA antibodies are more specific for lupus. Anti-Smith antibodies are also more specific for lupus. And you can see anti-histone antibodies. And what specific type of lupus did we say is associated with anti-histone antibodies, especially for your exam? Drug-induced lupus. Now these immunological markers are about a 3-star topic. There's a good chance you're going to be asked to know some of these. Now it's time for the end of session quiz. So pause the video, answer those questions, then restart the video and we'll go over the answers. First question, which rheumatologic disease matches each of the following descriptions? A man in his 20s with low back pain that improves with exercise would be ankylosing spondylitis. Pencil and cup deformities of the DIP joints are seen in psoriatic arthritis. Bamboo spine on X-ray is ankylosing spondylitis. Non-inflammatory arthritis affecting the DIPs and PIPs is typically osteoarthritis. And inflammatory arthritis affecting the PIPs and MCPs, but not the DIPs, is rheumatoid arthritis. Next, what factors tend to elicit joint pain and stiffness in rheumatoid arthritis? And what factors tend to relieve pain and stiffness? Well, in RA, the pain and stiffness are worse with rest and disuse, so you get morning stiffness and that gel phenomenon. And the joint pain is relieved by joint movement and use. And then, how does this differ from the pattern seen in OA? Well, in OA, it's just the opposite. The pain gets worse with use and gets better with rest. And the last question, what are the HLA-B27 positive seronegative spondyloarthropathies? So remember the mnemonic pair: psoriatic arthritis, ankylosing spondylitis, IBD arthritis, and reactive arthritis. That's it for now. I'll see you next time.
Hey man, long time no see. How you holding up? When they asked me to do this question on joints, I was totally stoked, you know, but then I saw the script. Totally wrong kind of joint, man. Anyway, what do you call the bony growths on the knuckles of patients with osteoarthritis? Right on, man. The ones on the PIP joints are called Bouchard's nodes, and the ones on the DIPs are called Aberden's nodes. And what about Osler's nodes? Man, there's no fooling you. Osler's nodes are painful lesions on the fingertips, not in arthritis, but in infective endocarditis. I threw a trick question at you, but you totally smoked it out. Get it? Far out.
It's time for another 3-question warm-up. Let's get going. A patient is suspected of having gastric cancer. Physical examination may show enlarged lymph nodes in which 2 locations? And then what are the names of those enlarged lymph nodes? So we have the left supraclavicular lymph node. That's going to be Virchow's node. And then we have the periumbilical one. Remember that has an interesting one. It's Sister Mary Joseph node. Next, what is the tumor marker for gastric cancer? And the answer to that is going to be CEA. Next, a patient presents to the clinic for follow-up and is found to have a blood pressure of 150/85. At his last visit 1 month ago, his blood pressure was 145/90. What is the most appropriate next step in the management of this patient? So you're probably going to want to, again, recheck the blood pressure in 2 to 4 weeks. So you have to have at least 3 elevated blood pressures on 3 separate occasions to make the diagnosis of hypertension. All right, that's it for the warm-up. Let's get to the lecture now.
The previous video was titled Arthritis, but we saved a couple of important types of arthritis for this video: gout and infectious arthritis. So let's start with gout. You should expect a question or two about gout on your exam. Gout's a form of arthritis where monosodium urate crystals precipitate out of the blood and they get deposited in the joints, usually the small peripheral joints like the first MTP joint. And then the inflammatory response to these crystals is what causes the arthritis and the pain. The number one risk factor for gout is hyperuricemia, or high uric acid levels, although not everyone who has hyperuricemia will develop gouty arthritis. But the hyperuricemia could be caused by underexcretion of uric acid, perhaps from loop diuretics or thiazides, or by overproduction of uric acid, or by increased consumption of purine-rich foods such as meat, especially organ meat, seafood, and alcohol. Excessive alcohol consumption is a big risk factor for gout because alcoholic beverages contain a lot of purines, and the body just converts those purines to uric acid. Obesity is another big risk factor, and so is male sex, because while women do get gout, it's more common in men. Gout classically causes acute attacks of sudden, severe monoarticular arthritis. These attacks usually begin at night for some reason, and the most common site is the first metatarsophalangeal joint. We call that podagra. Now, that's not the only joint that can be affected. You could have gout in the knee, or the ankle, or the hip, or the wrist, but the lower extremity joints are more common, especially the first MTP joint. The affected joint is usually red and warm and swollen, with inflammation that extends beyond the boundaries of the joint itself. And it's exquisitely painful and tender. Patients say they can't even stand for the sheets to touch their foot at night, and they really scream when you examine them. Now, patients with long-standing gout may develop something called chronic tophaceous gout, where they start to develop these tophi, or subcutaneous deposits of urate crystals. And these can form on the joints, on the tendons, on bursae, or even on the ear. They're not painful, and they're not inflamed, they're just masses of solid urate under the skin. But this is a rather uncommon presentation. Even though gout is caused by hyperuricemia, during the acute attack, the serum uric acid level can be either normal or increased. And if you do a joint aspiration, you're going to see needle-shaped, negatively birefringent crystals in the fluid and some white blood cells. Now, you probably already know this, but just to review, negatively birefringent means that you put a special filter on the light of the microscope, a special polarizing filter that filters out all the light that's going in every direction except one. So basically, the light is all lined up this way, and negative birefringence means that any crystals that are parallel to the direction of that light are going to look yellow. You can remember that the L's in the word yellow are two parallel lines. So these crystals look yellow when they are parallel to the direction of the polarized light. And you can see that this one is perpendicular to the polarized light, so it's blue. It's the same kind of needle-shaped urate crystal, but it's oriented perpendicular to our polarized light filter. You definitely need to be familiar with the treatment of gout. So what's the first-line treatment for gout? NSAIDs. That's a nice, safe answer for your test, although lots of people use a glucocorticoid such as prednisone. These patients are in a lot of pain. They can't walk sometimes. So you really want to get this under control quickly. So I usually just give prednisone for a week or so, and they're dramatically improved in a day or two. But NSAIDs are probably the best answer for your exam. You can use NSAIDs like naproxen, indomethacin, or even celecoxib. Another classic medication is colchicine, though it's not used nearly as often as it used to be. Now, what's the mechanism of action of colchicine? Colchicine inhibits microtubules and thereby inhibits migration of macrophages. So the macrophages can't move around, they can't migrate to the site of the crystals and cause inflammation. But the biggest side effect of colchicine is GI upset, like diarrhea and vomiting. We used to just give colchicine every hour until the patient got better or until they got diarrhea. It was kind of brutal. The current recommendation is that if you're going to use colchicine, which is about a third-line drug these days, you're going to give 2 low doses, and that seems to work just about as well as the old scorched earth regimen. But really, in the real world, colchicine isn't used that often. Mostly when you're treating acute gout, it's just NSAIDs or steroids. For longer-term management, to prevent recurrent attacks of gout, you need to keep the uric acid levels under control. So you can recommend lifestyle modifications, such as reducing consumption of alcohol and avoiding those purine-rich foods and reducing diuretic use. And you can give a drug called probenecid, which inhibits uric acid resorption at the kidney, or more often you'll give allopurinol, which inhibits uric acid production by inhibiting the enzyme xanthine oxidase. There's also a newer xanthine oxidase inhibitor called febuxostat. Now, colchicine can also be given long-term at lower doses to help with chronic gout. But probenecid and allopurinol and febuxostat are not used for acute gout. Make sure you know that. If you have a patient with acute gout and the uric acid level is high, you do not want to start allopurinol right away because that can actually make the acute gout attack worse. So you give the indomethacin or prednisone or whatever, and then once the acute flare is quieted down, then you start the allopurinol. Next up is pseudo-gout. So pseudo-gout is lower yield than gout, and it's less common in the real world, but you need to know about it because it can look a lot like gout. So you're going to see it as a distractor or a wrong answer choice on questions about gout. The official name of pseudo-gout is calcium pyrophosphate dihydrate deposition disease, or CPPD disease. Instead of uric acid crystals being deposited in the joints, with pseudo-gout you have crystals of calcium pyrophosphate dihydrate that are deposited in the joints. So you might use the P in pyrophosphate and the P in pseudo-gout to keep them straight, if that helps. Now, as you might guess, the clinical presentation is similar to gout, with acute attacks of joint inflammation, pain, redness, and warmth. But it commonly affects the knee. It can also affect the wrists, the elbow, the shoulder, the ankles, or feet, but the knee is the main joint. When you do an arthrocentesis, the joint aspirate shows positively birefringent crystals that are rhomboid shaped. So instead of those needle-shaped crystals like in gout, these are rhomboid crystals, and they're weakly positively birefringent, which is another P word. Pseudo-gout, pyrophosphate, positively birefringent. Now we said that urate crystals were negatively birefringent, so they were yellow when they were parallel to the polarized light. But positively birefringent calcium pyrophosphate crystals are blue when they're parallel to polarized light. But when they're perpendicular to polarized light, they look yellow. But to me, the shape of the crystal really gives it away. On X-ray, you're going to see chondrocalcinosis, or calcification of the articular cartilage of the joints. Chondro means cartilage, and calcinosis means calcification. So if you have a patient that comes in with knee pain and you get an X-ray to look for arthritis and joint space erosion, and instead you see that the cartilage and the menisci are calcified, they have these little traces of linear calcium deposits. And that suggests a diagnosis of pseudo-gout. The calcium pyrophosphate crystals are in the articular cartilage of the knee, especially in the menisci of both knees. And then for treatment, if there are only one or maybe two joints involved, you can do a steroid injection into the joint. If multiple joints are involved, you can use NSAIDs or colchicine. And for prevention of recurrent attacks, you can give colchicine for that as well. But obviously, allopurinol and probenecid are no good because those only affect uric acid metabolism. Now we're going to shift gears and talk about septic arthritis, which is a joint infection, typically a bacterial infection, which usually comes about when bacteria spread hematogenously from other sites. The most common pathogens are Staph aureus and Streptococcus, and then also consider disseminated Neisseria gonorrhea in young sexually active patients who have asymmetrical polyarthritis. This typically involves the knees, the wrists, and ankles, and may also be associated with pustules and papules on the hands or feet. Risk factors for septic arthritis include prosthetic joints, skin infection, IV drug use, alcoholism, pre-existing inflammatory arthritis, especially rheumatoid arthritis, diabetes, which predisposes to lots of infections, and recent joint surgery. Septic arthritis is typically monoarticular, meaning it's a single joint that's infected, and it causes pain, redness, warmth, tenderness to palpation, and often restricted range of motion. More than half of cases occur in the knee, although you can also see septic arthritis in the wrists or the hips or the ankles. But if you see a patient with acute arthritis in the knee who can't bend the knee, has restricted range of motion, think about septic arthritis. Or if you see a child who refuses to walk and bend that knee, think about septic arthritis. Labs will often show elevated SED rate and CRP and some leukocytosis. About 50% of patients will have positive blood cultures. But the best next step for a patient with suspected septic arthritis is to do a synovial fluid aspiration, where you stick a needle into the joint and draw out some of the fluid. Sometimes the fluid will be pus, but even if it isn't, you need to send the fluid for gram stain and culture, a leukocyte count, because the white cells will often be very high, greater than 50,000 white cells per cubic millimeter, and they're mostly neutrophils. And you also want to check the synovial fluid for crystals to rule out gout or pseudogout. For treatment, these patients need surgical drainage and irrigation of the joint, either arthroscopically or open drainage. We give antibiotics too, but this isn't the kind of infection where you just put them on antibiotics and wait and see. You get that synovial fluid sample, you draw your blood cultures, then you call the orthopedic surgeon right away. And you let the gram stain guide the choice of empiric antibiotics. If it's a gram positive, like staph or strep, you're going to start with vancomycin to make sure you're covering MRSA. If it's a gram negative, including Neisseria, you're going to start with a third-generation cephalosporin, like ceftriaxone. And if the initial gram stain is negative, you use vancomycin, because again, the most common cause of septic arthritis is Staph aureus. And then once the culture results and sensitivities come back, you can fine-tune your antibiotic regimen. Let's discuss Lyme disease, which is another infection that causes arthritis eventually. So first of all, what organism causes Lyme disease? It's the bacteria Borrelia burgdorferi, which is a spirochete. Then the vector is the Ixodes tick, most commonly Ixodes scapularis, which is commonly called the black-legged tick or the deer tick. Now it's usually the immature nymph forms that transmit the infection because they're very tiny, they're easy to overlook, so they're going to stay attached longer than the adults. They have to be attached for at least 2 days in order to transmit the Borrelia organisms. Most cases of Lyme disease in the U.S. occur in the Northeast and the upper Midwest, Wisconsin and Minnesota. The next question in the study guide asks, what are the classic presentation and clinical course of Lyme disease? So this is a disease that occurs in identifiable stages, kind of like syphilis, which is another spirochete infection. The first stage is early localized disease. About 80% of patients who get infected will have this, usually within 1 to 2 weeks of the tick bite. The main feature you'll look for is called erythema chronica migrans, which is a bullseye lesion or target lesion. It starts small and the redness sort of spreads outward gradually, and then eventually the center starts to clear, giving it that target appearance. Although if the patient comes in soon enough, the center may not have started to clear yet. This early localized stage may also be associated with constitutional symptoms like fatigue, headache, myalgias, and arthralgias, pretty nonspecific complaints. The next stage is called early disseminated disease, which occurs weeks to months after the tick bite. Now this can present a lot of different ways. It can cause lymphocytic meningitis, it can cause cranial nerve palsies, which can be either unilateral or bilateral. The most common cranial nerve involved is the facial nerve, and that results in Bell's palsy. Lyme disease is one of the very few things that can cause bilateral Bell's palsy or facial nerve paralysis. Patients may also have peripheral neuropathy or radiculopathy, problems with the spinal nerve roots. They can also develop carditis or ocular manifestations like conjunctivitis, keratitis, or uveitis. And then late Lyme disease occurs months to years after the onset of the infection. Even if the patient didn't have an obvious early phase, they could still potentially have this late phase if the infection continued and was never recognized and treated. But most patients do present early and are treated long before it ever gets to this stage. Late Lyme disease causes arthritis, especially in the knees, either a recurrent arthritis with episodes of joint pain and swelling, or sometimes it's more of a persistent arthritis. Late Lyme disease can also cause a mild encephalopathy characterized by mild cognitive disturbances. The diagnosis is pretty easy to make in the early localized stage. If you see that erythema migrans target rash in someone who lives in an area where Lyme disease is endemic or has traveled to those areas, you can make the diagnosis clinically and then start treatment. Early on, serologies are going to be negative, so you don't need any labs to make the diagnosis. Patients with early disseminated disease will be positive for both IgM and IgG antibodies to Borrelia. So we do an ELISA test first, and then we do a Western blot to confirm. And then patients with late Lyme disease won't have IgM antibodies anymore, but they'll still have IgG antibodies. So that's how you make the diagnosis. Then how do we treat Lyme disease? Well, for early localized Lyme disease, the preferred antibiotic is doxycycline, 100 milligrams twice a day for 14 days. Other options include amoxicillin and cefuroxime, and these are usually given for 3 weeks. Now, it's a little harder to make generalizations about early disseminated Lyme disease treatment because there's so many different clinical manifestations. If they just have isolated Bell's palsy, you're going to treat it with oral antibiotics, the same ones as in early localized disease, doxycycline, amoxicillin, or cefuroxime. But if the patient has meningitis or some of these other manifestations, you need to give IV antibiotics, such as ceftriaxone or cefotaxime or penicillin G, and often up to 28 days of IV antibiotics. And then patients with late Lyme disease and arthritis, you can treat with a 1-month course of doxycycline or amoxicillin. Now we're ready for the end of session quiz. So pause the video and work through those questions, then restart the video and we'll go over the answers. First question, what medications are used in the treatment of acute gout and acute pseudogout? So for acute gout, you can treat with NSAIDs, glucocorticoids, and possibly colchicine third line. But remember, probenecid and allopurinol are not used to treat acute gout. And then for pseudogout, you can use NSAIDs or colchicine. Next, which type of arthritis matches each of the following descriptions? Knee x-ray reveals calcification of the menisci. That's pseudogout, or calcium pyrophosphate dihydrate deposition disease. Needle-shaped, negatively birefringent crystals in the synovial fluid. That's gout. Rhomboid-shaped, positively birefringent crystals in the synovial fluid is pseudogout. Greater than 50,000 neutrophils in the synovial fluid is septic arthritis. 24-year-old man with pain and swelling in both knees plus pustules on the hands, that should make you think of gonococcal arthritis. Next, a 16-year-old boy presents with an expanding ring-like rash in the axilla, which began 2 weeks after a camping trip. What's the most likely diagnosis and the first-line treatment? So the diagnosis is Lyme disease, specifically early localized Lyme disease. And the first-line treatment is oral doxycycline for 14 days. And the last question. A 45-year-old woman presents with a swollen, warm, erythematous left knee. The joint's very tender to palpation and range of motion is extremely limited. What's the best diagnostic test and what's the most appropriate treatment? So when an acutely inflamed knee with decreased range of motion, that's going to make you think about septic arthritis. So the best diagnostic test is an arthrocentesis with synovial fluid aspiration. You're looking for white cells and bacteria in the fluid. And then the treatment is twofold. Surgical drainage and irrigation of the joint to clean out as much of the bacteria and pus as you can, plus empiric IV antibiotics, depending on the gram stain findings, either vancomycin for gram-positives or a third-generation cephalosporin like ceftriaxone for gram-negatives. That's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. In a patient with pancreatitis due to gallstone obstruction of the pancreatic duct, what should be done after the pancreatitis has resolved? Well, you're going to want to do a cholecystectomy. That's going to be the answer. Failure to perform that cholecystectomy is associated with an increased risk of recurrent acute pancreatitis. Cholecystitis as well, or even cholangitis, and that's even just within 6 to 18 weeks. Next, a 24-year-old woman comes to the physician for a health maintenance examination and is found to have markedly elevated blood pressure. She is at a recommended body weight, follows a good diet, exercises, and does not smoke or use birth control. Which secondary cause of hypertension should be considered in this patient? What would be seen on radiological imaging? Well, the most common cause of hypertension in a woman of reproductive age is going to be OCP use, but she's not on OCP. So the most likely diagnosis here would be a non-atherosclerotic renal artery stenosis caused by fibromuscular dysplasia. Now, an angiogram should be done looking for the beads on a string appearance of the renal artery. Next, which autoimmune condition is most likely seen in a patient with endocarditis caused by sterile vegetations of immune complex deposits? Liebman-Sachs endocarditis is going to be the non-infectious endocarditis seen in patients with systemic lupus erythematosus. All right, guys, that's it for the warm-up. Let's get to that video.
For this video, I brought along my favorite instrument, the trombone, because we're talking about bone diseases like osteoporosis and osteomyelitis and bone cancer. So let's start with osteoporosis. It's very common, it's very likely to show up on your exam. Osteoporosis is a state of decreased bone mass in which the osteoblast cells, which are responsible for building bone and laying down new bone matrix, are reduced in number relative to the osteoclast cells, which are responsible for resorbing that bone matrix so that the bone can heal and grow and remodel. And since the osteoclasts keep working normally, over time this imbalance between osteoblasts and osteoclasts results in mildly decreased bone mass, which we call osteopenia, and then eventually it leads to more significant bone loss, which is called osteoporosis. So over here on the left you see healthy bone with these nice, thick, strong bony trabeculae. But over here, this patient has reduced bone mass and thinning of the trabeculae. The bone becomes porous and more fragile and more prone to fractures. It's osteoporosis. It's porous bone. So that's what osteoporosis looks like at the microscopic level. Osteoporosis is largely a disease of the elderly, especially elderly women, because one of the major risk factors is decreased estrogen. So being a postmenopausal woman is the #1 risk factor by far. But decreased estrogen from hypogonadism or a prolactinoma or anorexia or any number of other things will also increase a woman's risk of osteoporosis. In men, decreased testosterone is associated with an increase in osteoporosis. Now, race is a risk factor. Asians and Caucasians are more likely to get osteoporosis than blacks are. Another risk factor is a sedentary lifestyle. Weight-bearing exercise actually helps increase bone mass because the tugging of muscles on the bone seems to stimulate the osteoblast. So a sedentary lifestyle will increase your risk of osteoporosis. Another risk factor is low body weight. Being obese is bad for almost every disease you can imagine except osteoporosis. Obesity actually protects you from osteoporosis a little bit, possibly because you're doing a lot more weight-bearing exercise just by walking around normally.
So being a thin, postmenopausal white woman or Asian woman is sort of the trifecta of risk factors for osteoporosis. Smoking is a risk factor, and so is alcohol. Inadequate calcium intake will increase your risk. Hyperparathyroidism and hyperthyroidism and use of glucocorticoids are all risk factors too. And sometimes even patients with hypothyroidism can develop osteoporosis if their dose of thyroid hormone is too high. Now, osteoporosis is usually asymptomatic until it causes fractures. These patients are at risk of wrist fractures, femoral neck fractures, and hip fractures.
And vertebral compression fractures, which may or may not be painful. These compression fractures eventually lead to pronounced kyphosis and loss of height. This is one reason that older people seem to be shrinking. The labs are usually normal in osteoporosis. Alk Phos is normal, and calcium is generally normal unless the patient has some hyperparathyroidism that's causing the osteoporosis. You can often see evidence of osteoporosis on x-rays because the bones don't look as radio-opaque as normal. They're easier to see through. That's not how we formally diagnose it. To formally diagnose osteoporosis, you have to do a bone mineral density test, which is also called a DEXA scan, a dual energy X-ray absorptiometry scan. You're basically measuring how much X-ray radiation is passing through the bone at the spine or at the hip. If the bone is nice and healthy and dense, it will absorb more of the X-rays. But if most of the X-rays pass through the bone, you know that the bone mass is reduced. Now, I'm told that some students have seen questions where they're asked to interpret these DEXA scan results. So briefly, when the scan is reported, the computer will calculate for you something called a T-score. The T-score basically compares the patient's bone density to the average bone density of a young adult of the same sex and race. So if you're a 65-year-old woman, they aren't comparing your bone density to other 65-year-old women. They're comparing your bone density to the bone density of 30-year-old women. And if your bone density is one standard deviation above that average, they assign you a T-score of +1. If your bone density is one standard deviation below the average, the T-score is -1. If your bone density is 2 standard deviations below the average, your T-score is -2, and so on. So if the patient's T-score is -1 or higher, more positive than -1, that's considered normal bone density. If the T-score is between -1 and -2.5, that's considered osteopenia. And a T-score lower than -2.5 is considered osteoporosis. You won't be asked to do any calculations with that, but it may be worthwhile to memorize those thresholds. Then, once you've diagnosed osteoporosis with a bone density study, how do we treat it? And how can we prevent it? Well, first of all, there are lifestyle changes. Smoking cessation and reducing alcohol are both important. Weight-bearing exercise can improve bone mass, as we discussed. Calcium and vitamin D supplementation is very important. Make sure that the osteoblasts have enough building blocks to build bone matrix. But the mainstay of prevention and treatment is bisphosphonates, such as alendronate, risedronate, and abandronate. These work by inhibiting osteoclasts. Now, we used to give hormone replacement therapy to these postmenopausal women just to prevent osteoporosis, and that worked pretty well. But there are some concerns that HRT may increase the risk of MI and strokes and DVTs. So, because of these risks, osteoporosis by itself is no longer an indication for hormone replacement. But the selective estrogen receptor modulator raloxifene will have the same effect of reducing osteoporosis without an increased risk of heart disease or stroke. But raloxifene does increase the risk of DVT and PE. So as far as the risk of clotting is concerned, it's not a lot better than hormone replacement therapy. And there's teriparatide, which is a pulsatile PTH analog. If you give PTH continuously, it causes hyperparathyroidism, which stimulates the osteoclast to resorb bone, and that makes osteoporosis worse. But pulsatile PTH actually stimulates the osteoblast to lay down healthy new bone matrix. So teriparatide is a subcutaneous injection that the patient gives herself once a day for 2 years, and that stimulates the osteoblast. There's also a drug called denosumab, which is a rank L inhibitor that inhibits osteoclast activity. The next bone disease is osteopetrosis. This is one that you'll probably never see except on your boards, and maybe not even then. It's much lower yield than osteoporosis. Petra is Greek for stone or rock, so this is rock-like bone. If osteoporosis was porous bone, this is osteopetrosis or rock-like bone. This is a genetic disease that causes impaired osteoclast activity. So the osteoblasts are laying down new bone, but the osteoclasts are impaired, so they're not able to break down the bone. And the end result is abnormally dense bone. Unfortunately, this isn't healthy, normal bone, and these patients have increased risk of fractures. This can also cause hearing loss because of excessive bone growth that narrows the auditory foramen and compresses the acoustic nerve. Or it can compress the optic nerve and cause vision loss. The thickening of the bones can also obliterate the marrow space, which leads to pancytopenia, anemia, thrombocytopenia, leukopenia, and that leads to infections. These patients can also get thickening of the bones in the skull, so that the patient may complain that his hats don't fit anymore. We're going to see that again with Paget disease of bone in just a minute. But osteopetrosis is a pretty rare disease overall. Paget disease is more common. As in osteoporosis, the bone labs will generally be normal. Calcium, phosphate, and alkaline phosphatase are all usually normal. And I mentioned that you may see some pancytopenia. X-rays of the long bones may show ends that have flared out, kind of like an Erlenmeyer flask. And then the treatment is kind of interesting. This is a defect of osteoclasts, right? Well, osteoclasts are basically macrophages of the bone. They're derived from monocytes. So you can treat osteopetrosis with a bone marrow transplant to introduce monocytes that don't have this genetic enzyme defect that renders them incapable of resorbing bone. So a bone marrow transplant is potentially curative. Our next condition is Paget disease of bone. Now this is completely different from Paget disease of the breast. Same Dr. Paget, but two distinct diseases. Paget disease of the bone is at least a 3-star topic, maybe 4 stars. It's a common finding in the elderly, but it often isn't recognized or diagnosed. Paget disease is caused by focal areas of excessive bone remodeling. Not all over the skeleton, just focally, here and there in discrete lesions. It starts with overactivity of the osteoclasts, breaking down the bony matrix, and then eventually the osteoblasts try to catch up by laying down new matrix. And then eventually after that, the osteoclasts kind of burn out, and only the osteoblasts are working overtime. So again, osteoporosis is an osteoblast deficiency, and osteopetrosis is an osteoclast deficiency, and in Paget disease, both osteoclast and osteoblast are overactive. Paget disease is usually found in the axial skeleton, the skull, the spine, and the pelvis, and sometimes in the long bones of the legs. These patients are usually asymptomatic, but this excessive bone turnover isn't good for the bones. Now, if symptoms do arise, they could include bone pain, arthritis, bone deformity such as bowed tibias or kyphosis, or increased risk of fracture because this new bone being laid down is disorganized and weak. And because this tends to involve the axial skeleton and the skull, it can impinge the acoustic nerve and lead to hearing loss, just like we saw with osteopetrosis. And again, you can see increases in the skull circumference. This is a CT of the head of a patient with Paget disease of bone, and you can tell that the skull is just super thick. So if they give you a patient who says his hat size is getting bigger or who says his hats are getting too tight, think about either Paget disease or osteopetrosis. So how can you distinguish the two? Well, for starters, osteopetrosis is extremely rare and Paget disease isn't. So in a pinch, guess Paget. But we're scientists, right? We can be more precise than just making a lucky guess based on averages. In osteopetrosis, we said that the bone labs are all normal. In Paget disease, the calcium and phosphorus and PTH are normal, but the alkaline phosphatase is elevated. Alk phos that comes from the bone reflects the cellular activity of osteoblast. In other words, an elevated bone-specific alk phos is a marker of bone formation. So again, in osteoporosis and osteopetrosis, the osteoblasts aren't working any harder than normal, so the alk phos is normal. But in Paget disease, once those osteoblasts do get ramped up, the alk phos will be high. Radiology is also pretty helpful. X-rays may show osteolytic lesions, which are focal hyperlucent areas in the bone where the osteoclasts are chewing up the matrix. You may also see hyperdense sclerotic lesions, where the osteoblasts are aggressively laying down new bone. And on a radionuclide bone scan, these areas of active disease will show up as hot spots. So you can make the diagnosis with the plain X-ray, but then you need the bone scan to document how many lesions there are, since lytic lesions can sometimes be hard to spot. Patients with asymptomatic Paget disease generally don't need to be treated. Patients with symptoms like bone pain or fractures or really elevated alk phos can be treated with bisphosphonates, just like osteoporosis, and then subcutaneous calcitonin injections can be helpful as well. But again, most cases are asymptomatic and they don't require treatment. I also want to mention one potential complication in passing, and that's that these patients are at an increased risk of developing osteosarcoma, which is a kind of bone tumor. And that kind of makes sense if you think about focal areas of disordered bone growth leading to bone cancer. Let's talk about osteomyelitis, which is an infection of the bone, usually a bacterial infection. Now, we said that joint infection or septic arthritis usually occurs due to hematogenous spread of an infection. And you can see hematogenous spread of infection causing osteomyelitis as well. But a major cause of osteomyelitis is contiguous spread of infection from the adjacent skin or soft tissue, like a diabetic foot ulcer that just keeps invading deeper and deeper and deeper until the infection eventually gets to the bone. You can also get osteomyelitis from direct inoculation of bacteria into the bone from trauma or from surgery. Osteo due to contiguous spread or direct inoculation is usually polymicrobial, but the most common bacteria are Staph aureus, coagulase-negative staph species like Staph epidermidis, which is commonly found on the skin, and then gram-negative bacilli, things like E. coli, Klebsiella, and Salmonella. Now, a couple of special populations to be aware of. In sickle cell patients with osteomyelitis, Salmonella is the most common cause, at least in the U.S. And in IV drug users who get osteomyelitis, you need to think about Pseudomonas. These are both examples of hematogenous spread. And hematogenous spread osteomyelitis is more likely to be monomicrobial rather than polymicrobial. And in patients with a diabetic foot ulcer, you need to consider Pseudomonas as well. Now, osteomyelitis usually causes dull bone pain that develops gradually over several days. There may be some fever and some swelling and redness of the overlying skin, but don't count on it. Osteomyelitis is notoriously sneaky. And the labs aren't always a huge help either because they're so nonspecific. Leukocytosis, elevated SED rate and CRP, possibly positive blood cultures. But again, all those values might be normal. Sometimes you just have to have a really high index of suspicion to think about osteomyelitis and then go looking for it. X-rays may show erosion of the bone cortex and a periosteal reaction, but a normal X-ray doesn't really rule out osteo. An MRI is a much more sensitive and specific test. And if you have a patient with fever and leukocytosis, but you don't have an obvious source of infection, a nuclear medicine study like a technetium bone scan or a gallium scan or a tagged white blood cell scan may be really helpful. But for step 2, MRI is probably the best choice. And then to identify the pathogens to guide treatment, you need a surgeon to do a bone biopsy and culture the bone. Treatment may require surgical debridement of necrotic bone plus IV antibiotics. Empiric therapy is usually vancomycin to cover MRSA plus something like cefepime to cover gram-negatives. And then once the culture results are available, you can fine-tune the antibiotic regimen. And this often requires IV antibiotics for at least 6 weeks. Now, if there's infection in the bone around orthopedic hardware, like a prosthetic knee or a hip, that hardware usually needs to be removed. And sometimes, if the infection is bad enough and there's significant destruction of bone tissue, these patients end up needing amputation. Now we're going to shift gears and talk about some bone tumors. So, what's the most common type of malignant bone tumor in adults? Metastatic disease. The cancer started somewhere else and then it metastasized to the bone. Primary bone tumors are much less common. So what kinds of METs are we talking about? Well, students sent us a good mnemonic for these. Permanently relocated tumors like bones. So the P is for prostate, the R is for renal cell cancer, the T in tumors stands for 2 things, testes and also thyroid. The L is for lung and the B is for breast. Lung cancer and breast cancer love to metastasize to other organs like the bone, the brain, and the liver. And also notice the genitourinary association here. Prostate, testes, and renal cell cancer all like to go to the bone. Bone METs may result in some bone pain. You can also see pathological fractures and possibly some hypercalcemia with lytic bone lesions. For example, lung METs tend to cause lytic bone lesions, which means they're breaking down the bone at the site of the METs. Prostate cancer, on the other hand, causes blastic bone lesions. They actually build new bone, but that new bone is disordered and weak and it fractures pretty easily. And then breast cancer METs to the bone can either be lytic or blastic. Now let's go over this table of primary bone tumors. These are not very high yield for step 2. You can usually get away with just knowing a few buzzwordy facts about each of these. But be sure you can recognize the tumor based on its appearance on X-ray and also its location in the bone. The first type of tumor is an osteosarcoma, which is the most common malignant primary bone tumor. It's most common in teenage boys, and it's also seen in adults over 65 because it can arise from Paget disease of the bone, as we discussed. Now, in kids, it's associated with the hereditary retinoblastoma gene mutation. Retinoblastoma is a malignancy of the retina, but individuals with this mutation are also at risk of getting osteosarcoma. It can be associated with prior radiation therapy or chemotherapy. So a child who had cancer at a young age and was treated with radiation might get an osteosarcoma 10 years later. Like most bone tumors, this presents with bone pain, and it's usually found near the knee, either the distal femur or the proximal tibia. Now, the 2 X-ray findings you need to be able to recognize are Codman's triangle, which is where the tumor pushes the periosteum up from the surface of the bone, forming this little triangular density on X-ray. And then there's this classic sunburst pattern to the tissue, which is kind of pretty to look at, except this is a cancer that's going to kill you. And this is treated with surgery plus chemotherapy to make sure you kill any microscopic mets. We used to have to do amputations on these patients, but these days limb-sparing surgery is usually possible. The next type of tumor is a Ewing sarcoma. This is an extremely aggressive tumor that typically occurs in young boys under 15. It's usually associated with an 1122 translocation. It also arises in the long bones of the extremities or in the pelvis. Ewing sarcoma tends to grow on the surface of the cortical bone, and on X-ray you can see destruction and disruption of the cortex. This is known as an onion skin appearance because it kind of looks like layers of an onion. Now, some students like to think about eating wings and onion rings. Wings for Ewings and then onion rings for this onion skin appearance. Treatment includes chemotherapy plus surgical excision. The next tumor is a giant cell tumor of the bone, which is a tumor that contains multinucleated giant cells that resemble osteoclasts. So sometimes this is called an osteoclastoma. But it's not really a tumor derived from osteoclasts. The cells just sort of resemble osteoclasts. These occur in slightly older individuals, young adults in their 20s and 30s. They're most commonly found on the distal femur or the proximal tibia, just like osteosarcoma. The X-ray shows something called a soap bubble appearance. So this roundish lucency is the tumor, kind of like a soap bubble within the bone. Those osteoclast-like cells are breaking down the bony matrix and causing lytic lesions. These are generally benign tumors, but they're locally destructive. They grow and destroy nearby tissue, so they need to be treated, primarily with surgery, although radiation is an option for unresectable tumors. And then finally there's osteochondroma. This is the most common benign bone tumor. It tends to occur in young males under 25, and it causes a painless bone mass which is often palpable. These look like great big bone spurs with a cartilage cap on them. Now, some students use the CH in osteochondroma to stand for chunk, because this looks like a big chunk of bone that's sort of stuck onto the bone. This is one that does not need to be treated, generally speaking, unless it causes deformity of the bone by interfering with the growth plate or some local soft tissue irritation. Now we're ready for the end of session quiz. So pause the video, work through those questions, and then we'll go over the answers together. First question. A patient with suspected osteomyelitis had a non-diagnostic X-ray. MRI is not available. So what's the best test to make a definitive diagnosis of osteomyelitis? You need to do a bone biopsy and culture the biopsy material. Next, a 60-year-old man is in the clinic for a checkup. He's a new patient and you notice his legs are bowed out. He's also bent forward with kyphosis and he's hard of hearing. He has no complaints besides his favorite hat not seeming to fit anymore. He claims the hat feels smaller. So what's the most sensitive imaging to diagnose this process? Well, the diagnosis here is Paget disease of the bone, and the diagnostic test to order is a radionuclide bone scan. You're going to look for regions of elevated metabolic activity called hotspots. Next, what's the classic radiological appearance of an osteosarcoma? You can see the sunburst pattern and Codman's triangle. And then for Ewing sarcoma, you look for a large destructive lesion with a periosteal reaction called onion skinning. Next, a patient presents with bone tenderness and is found to have elevated white cell count, elevated CRP, and elevated SED rate. So what's the most likely diagnosis? Osteomyelitis. And the last one, what organism is the most common cause of osteomyelitis overall? That's Staph aureus. Now what organism should be kept in mind for sickle cell patients and for IV drug users? So for sickle cell patients, you're going to think about Salmonella, and for IV drug users, think about Pseudomonas. That's it for now. I'll see you next time. Let's go over the answers to the 3-question warm-up. First question, what are the Ranson criteria for determining the prognosis in patients with acute pancreatitis? So remember, the mnemonic for the Ranson criteria on admission was Georgia Law, or GA Law, for glucose, AST, LDH, age, and white cell count. Now remember, you don't really need to memorize the exact numbers, just know these different components. And then the mnemonic for Ranson's criteria in the first 48 hours after admission is Calvin and Hobbes, which is calcium, hematocrit, O2, BUN, base deficit, and sequestration of fluid. Next, what are the components of the medical management of peripheral artery disease, PAD? Well, you want to have the patient stop smoking, so smoking cessation is very, very important. Exercise is important, glucose control, good diet, blood pressure control. You can also use the medication cilostazol. And the last question, which class of antihypertensives is contraindicated in patients with COPD? Well, that's going to be non-selective beta blockers like propranolol, because they might cause some bronchoconstriction in patients who have COPD or asthma. All right, let's move on to the lecture.
Hi all, Dr. Carmichael here. Today we'll be talking about orthopedics for step 2. This is just part 1, and we'll be covering carpal tunnel syndrome, dislocations, and fractures today. Let's start with carpal tunnel syndrome, which is definitely a high yield topic. You're going to see this on the boards, but more importantly, you're going to see this in practice. Carpal tunnel syndrome is a median nerve compression at the wrist. You don't need to have all the anatomy memorized, but it may be helpful to think of it as a box with bones on 3 sides and a transverse carpal ligament as the lid. It is the median nerve that is getting compressed inside this box. Risk factors include obesity, being female, pregnancy, diabetes, rheumatoid arthritis, hypothyroidism, connective tissue disease, and overuse. Activities requiring a lot of wrist motion, like typing, playing piano, writing, or mechanic work. The most important physical finding is going to be numbness in the thumb and in the index fingers. You can also have it in the middle finger and on the radial half of the ring finger. This is the sensory distribution of the median nerve. These symptoms can be episodic or constant and typically associated with activity or time of day. And though the sensory deficit should be limited to this area, the pain, if it is present, that is associated with carpal tunnel can encompass the entire hand or even radiate back up the arm. In more severe cases, patients will have motor symptoms of the hand that can result in weakness and muscle atrophy. Very commonly, the chief complaint is a loss of grip strength or clumsiness. Physical exam can be normal. Sensation should be tested in all regions of the hand. There are 2 provocative tests called the Tinel sign and the Phelan sign. The Tinel sign is where you tap over the carpal tunnel, and this can reproduce the symptoms. Or the Phelan sign is where you place the dorsal side of the hands together and flex the wrist 90 degrees. This can normally cause an onset of symptoms in under a minute. But you don't always have to have these signs with carpal tunnel. And just remember, the Tinel's is tapping and the Phelan's is flexing. To definitively diagnose carpal tunnel, you need to obtain nerve conduction studies and an EMG. Treatments for carpal tunnel include wrist splints, especially at night, in a cocked up position, activity modification, stop doing what makes it worse, NSAIDs sometimes will help, and glucocorticoid injections, and finally, surgical release of the transverse carpal ligament. Let's move on to dislocations. This is at least a 3, maybe 4-star topic, and it's very common to have questions about shoulder dislocations on your test. The most common type of shoulder dislocation is an anterior dislocation, which is where the shoulder is abducted and externally rotated, and the humeral head is pushed forward and tears the anterior labrum and capsule of the shoulder. So on the top x-ray, the humeral head is lying medial to the glenoid and inferior to the coracoid process. On the bottom right image, we see the transverse scapular projection, or Y projection. The arrow is pointing to the empty glenoid process, and the humeral head, H, is medially and anteriorly displaced. I think some of the hardest material regarding dislocations is the difference between an anterior and posterior dislocation. Let's go through some of the differences. When there's an anterior dislocation, arm position is key. The arm is held externally rotated and slightly abducted. For neurovascular compromise, the axillary artery and nerve are at risk. The classic scenario is a blow to an abducted and externally rotated and extended arm, like you're trying to block a basketball shot or make a tackle. On exam, you'll see a prominent acromion process if the patient is thin, and a loss of normal shoulder roundness. Let's see how this is different from the posterior dislocation. X-ray signs can be very subtle in a posterior dislocation and go undetected on an AP image. One sign is called a light bulb sign. The light bulb sign is seen because the humeral head is slightly internally rotated and the tuberosities are no longer projected laterally. This makes the humeral head look more like a light bulb. It's kind of circular and smooth. There are also greater than normal overlap between the anterior glenoid rim and the medial aspect of the humeral head. On this image, there's less of a light bulb sign, but you do see that overlap of the humeral head and the anterior glenoid rim. Neurovascular compromise is unusual with a posterior dislocation. This scenario is normally a blow to an anterior shoulder, often when a patient had a seizure or received an electrocution and they fall down and landed on the anterior surface of the shoulder, pushing it posteriorly. For physical exam, the shoulder is more prominent posteriorly and anterior shoulder is flat. What is the treatment for an acute anterior shoulder dislocation? First of all, make sure the X-ray confirms your diagnosis and confirms that there isn't a fracture present. If so, you're going to need an orthopedic surgeon. There are several options for pain control in these patients. You can inject lidocaine into the glenoid cavity. You can use narcotics, a lot of narcotics, to control their pain. And sometimes you even have to go to conscious sedation just to get it back in, depending on how long it's been out. There are a lot of different ways to reduce a dislocated shoulder. I don't think you need to know the details of each one on the test, but they're good for you to know for your residency. The names include the Stimson maneuver, scapular manipulation, external rotation, the Milch technique, Spazo technique, and the traction countertraction. After you've reduced the shoulder, you should immobilize the arm with a sling and re-x-ray the shoulder to make sure you got it in place. Check to make sure there's no neurovascular compromise, normally by pinching on the outside of their shoulder, and have the patient follow up with an orthopedic surgeon. If you dislocate your shoulder once, you are more likely to dislocate it again. 96% of dislocations have an anterior labral tear, especially with an anterior dislocation. These don't always require surgery, but orthopedic surgeons are becoming more aggressive with surgical repair of Bankart tears, even in first-time dislocators. Let's also briefly touch on hip dislocation. This is most commonly a posterior hip dislocation via a posteriorly directed force on an internally rotated, flexed, and abducted hip, such as ramming your knee into a dashboard during a car collision. The treatment for this is closed reduction, bracing, and abduction pillow. It's a little triangle-shaped pillow with straps that hold the hip in the correct location for the healing. After relocation, an X-ray should be taken to prove that normal joint alignment has been established and that there is no acetabular or socket fractures or chips retained inside the hip. Next, we're going to go over a variety of different fractures, but before we do, I want to briefly touch on the nerves of the upper extremity. Hopefully, some of this is still in your brain from step 1. Unfortunately, some of this is just memorization. We don't have a lot of time to do a full anatomy lesson on each of these, but at very least, we should learn the buzzwords. First, let's start with nerve damage that leads to hand deformities and weakness. Those are fancy and high yield. The first we're going to talk about is the ulnar claw. The ulnar nerve innervates the third and fourth lumbricals, the interosseous muscles, and the adductor pollicis. The most important part is to remember what the lumbricals do. They act to flex the MCP joints and extend the interphalangeal joints. So, with an ulnar injury, you will have hyperextension of the MCP and flexed at the IP joints of the fourth and fifth digits, so it looks kind of like a claw. This is apparent when you ask the patient to extend their fingers. The next one we're going to talk about is ape hand deformity. This is due to a median nerve injury. The median nerve roughly takes care of flexion of the wrist and fingers and pronation. We talked about carpal tunnel syndrome. That was a median nerve pathology in the wrist. If you damage the median nerve at the elbow, you can get the ape hand deformity. Patients will have loss of innervation of the thenar muscles of the hand, and the patient is unable to abduct the thumb. You can also get a median nerve damage further up the arm that can result in the hand of benediction or the Pope's blessing. Here the patient loses the ability to flex the second and third digits, the index and middle fingers. So when you ask the patient to make a fist, they can flex the pinky and the ring finger, but they can't flex the index or middle finger. So what does that look like? It looks a lot like the ulnar claw. The difference is that a patient with ulnar claw can't extend the pinky or ring finger. Those fingers are chronically flexed. And the hand of benediction is the only apparent when you ask them to make a fist. They cannot flex the index or middle finger. So when their hand is relaxed, it can look like almost normal, where the ulnar claw relaxed always looks abnormal. The last interesting hand deformity is wrist drop. This is due to radial nerve damage. The clinical scenario is called Saturday night palsy. A drunk patient or medical student passes out with his or her arm draped over the back of a chair. This causes radial nerve compression against the spiral groove in the humerus. The result is the inability to extend the wrist or wrist drop. So okay, those are the really cool ones, but there are a few nerve injuries that I just think you need to know the buzzwords, and let's go through a few of those. Scapular winging is a long thoracic nerve injury. Unable to wipe their bottom? Look for a thoracodorsal nerve injury. Loss of shoulder abduction is an axillary nerve injury. Loss of elbow flexion and forearm supination, this is a musculocutaneous nerve injury. Trouble initiating shoulder abduction, it's a suprascapular nerve injury. Unable to abduct the arm beyond 10 degrees, it's an axillary nerve injury. Unable to raise your arm above the horizontal, this is a long thoracic and spinal accessory nerve injury. Knowing those nerve injuries is probably a 3-star topic. It's very likely you're going to get one of those on your test. The next section is a list of very specific injuries or fractures that lead to very specific nerve injuries. So we just learned what we see with these nerve injuries. Now let's look at what injuries lead to that pathology. Again, I would really just memorize the buzzwords here, not go too deep into these. Fracture of the shaft of the humerus is going to get the radial nerve. Fracture of the surgical neck of the humerus is going to get the axillary nerve. Supracondylar humerus fracture is going to get the median nerve. A fracture of the medial epicondyle will get the ulnar nerve, and anterior dislocation is going to get the axillary nerve. Injury to the carpal tunnel is going to be the median nerve. All right, now we're ready to talk about fractures. Let's start with the Colles fracture. It involves the distal radius, and it can involve the distal ulna. There's classically a history of a fall onto an outstretched hand, or a Fuchs fracture. The forearm is dorsally displaced and angulated, a dinner fork deformity. This is a very common scenario. You trip and you fall on your arm. Most people that have normal bone density don't get a Colles fracture. So this is a common fracture you see in patients with osteoporosis. So if you see someone with a Colles fracture, think about osteoporosis. In the emergency department, you'd apply a sugar tongue or a reverse sugar tongue, and if it's non-operative, a long arm cast after the swelling goes down. Remember, neurovascular compromise is a good indication to refer to an orthopedic surgeon. You don't have to immobilize the shoulder here, but the shoulder sling might be helpful to carry on the way to that cast. The next one we're going to talk about is a Smith fracture, which is a fracture of the distal radius, but the distal part of the radius ends up being volarly anteriorly displaced. So if that distal radius is posterior displaced, that's a Colles fracture, but anterior displaced, it's a Smith fracture. This occurs when you fall or land on your flexed wrist, but overall this is much less common. Most people try to land on their hands, not their wrists. Treatment is similar with splints, casting, and surgery. Let's move on to the scaphoid fracture, which is a very commonly tested fracture. Because of the anatomical snuff box, it's a very important site of tenderness. The snuff box is also just fun to say. The classic scenario is a fall on the radially deviated outstretched hand. If the patient presents to you with wrist pain, you need to check the anatomical snuff box for tenderness. The x-rays may look completely normal, but if you have tenderness over that snuff box, it could be a scaphoid fracture until you prove it otherwise. You still have to treat it like it is broken. You immobilize the wrist with a thumb spica cast or splint and follow up with another x-ray in a week or two if the symptoms are still going on. The reason why you do this and why it's so important is because scaphoid fractures have a very high rate of non-union and can lead to avascular necrosis, or AVN. The scaphoid fracture is the most common carpal tunnel bone fracture. The next fracture we're going to talk about is the boxer's fracture. This fracture is of the 5th metacarpal neck. It occurs when you punch a hard object, like a wall or a face. How do we treat this? Again, you don't necessarily need surgery for this one. You might get away with a closed reduction, but sometimes surgical pinning is necessary. You should also be suspicious of a possible fight bite. If you get this boxer fracture from being in a fight, you might have a bite injury. Open wounds from teeth will need to be surgically explored to rule out tendon involvement, and the patient will need copious irrigation and antibiotics. Human mouths are gross. A humerus fracture will occur with a motor vehicle accidents and blunt trauma. A humerus fracture can be associated with a radial nerve injury, which might leave a patient with wrist drop or weakened thumb abduction. A Monteggi fracture is a dislocation of the radial head and the proximal third fracture of the ulna. This can be seen in a fall onto an outstretched hand with the forearm in excessive pronation. It will require surgery. A Galazzi fracture is a fracture of the midshaft or distal radius with dislocation of the distal radial ulnar joint. Again, this will require surgery. Try not to confuse the Monteggi fracture, which is an ulnar fracture and a radial head dislocation, with the Galazzi fracture, which is a radial fracture. It is very easy to confuse them, and both of them are associated with trauma. The hip fracture is particularly common in osteoporotic patients following a fall. You can possibly see a hip fracture in a motor vehicle accident. It's a common ski injury. It can also occur in any sort of strong axial force. These are definitely needing surgical repair. There are 3 types of hip fractures: femoral neck, intertrochanteric, and subtrochanteric. There is an increased risk for avascular necrosis in a femoral neck fracture. Under the history and physical will be a little old lady who fell and now has an injured leg, which is shortened and externally rotated. Femur fractures are big injuries caused from more severe trauma. A femur fracture definitely needs surgical repair. There is also an increased risk for fat embolization, which may present with unexplained hypoxemia and petechia. Trauma evaluation should include cervical spine radiographs, pelvis exam, serial hematocrits, compartment exam, and a secondary assessment for anything else that may be caused by the mechanism of injury. Moving on to the next one is a tibial fracture. The main thing to know about a tibial fracture is that it can cause an increase in the risk of compartment syndrome. We will talk about compartment syndrome in another video. The last one we're going to talk about is a pelvic fracture. Pelvic fractures are discussed in the trauma section, but there is a lot of high-risk major blood loss issues here. What is the first thing you do once you diagnose a pelvic fracture? Decrease the pelvic volume. This can be done with a pelvic binder, sandbags, or just a sheet tied around the patient to close the pelvis back up so that there isn't as much blood to fill that space. One last thing here, guys. It may not be super high yield for your test, but it will be high yield for your future practice. Any fracture that's open or has neurovascular compromise needs to have an orthopedic surgeon involved. And if you have a dislocation that you can't get back in, or that you got back in and it pops right back out, you need to get an orthopedic surgeon. But that's it for fractures. Let's go on to the end of session quiz. All right, guys, first question. What is the classic symptoms of carpal tunnel syndrome? Remember, it's numbness in the first, second, and third digits of the fingers, and maybe the radial half of the fourth digit. Remember, you can look for the Tinel sign or the Phelan sign. And with chronic carpal tunnel syndrome, you can have thenar muscle atrophy. What is the difference between a Monteggi fracture and a Galazzi fracture? A Monteggi fracture is a proximal ulnar fracture with an anterior dislocation of the radial head, while a Galazzi fracture is a radial fracture with dislocation of the distal ulnar radial joint. Last question, guys. What complication should you look for with each of the following types of fractures or injuries? A fall on an outstretched hand followed by a snuff box tenderness. This is most likely a scaphoid fracture, and the complication is a risk of avascular necrosis. Anterior shoulder dislocation, complication is an axillary nerve injury. Fracture of the fifth metacarpal neck, that's a boxer's fracture, and most commonly seen with a patient who has punched something or someone. So you're going to have to worry about an abscess from a bite wound, that fight-bite injury, or possible tendon laceration. A humerus fracture, complication is a radial nerve injury. Hip fractures, you got to be worried about avascular necrosis. A femur fracture, you worry about severe blood loss and also fat embolus. Tibial fractures are high risk for compartment syndrome. And pelvic fractures, think about hypovolemic shock from the blood loss. That's the end of this lecture, guys. We'll see you next time.
Let's get started with a 3-question warm-up. First question, a patient comes to the emergency room with severe abdominal pain and is found to have free air in the abdomen on imaging. So what's the most appropriate next step in management? Well, free air in the abdomen means there's a perforation. We're usually going to see free air on an upright abdominal film, or possibly on a chest x-ray. But the next step in management is an exploratory laparotomy to find the perforation and repair it. Next, a patient with suspected cholecystitis has an equivocal ultrasound. What's the most appropriate next step in the evaluation of this patient? That's going to be a HIDA scan. That's going to tell you pretty definitively if there's any obstruction of the cystic duct. Last question. A 45-year-old obese woman with pruritus, clay-colored stools, and dark urine is found to have elevated alk-phos and bilirubin. So what's the most likely cause of these findings? Well, there's some type of biliary tract obstruction. Lots of potential etiologies here. In a 45-year-old obese woman, you'd immediately suspect gallstones, but all you can definitively say is that there's biliary tract obstruction. Now let's get started with the lecture.
We're going to be continuing our orthopedics review. We're going to start with sprains. A sprain is an injury to the ligaments and surrounding soft tissues in a joint. Structures are partially or completely torn at the ligament-bone interface or within the ligament substance. The most common sprains are the ankle and the knee. Sprains present with pain involving the joint and with weight bearing or movement of that joint, and tenderness at the ligamentous insertion. Typically, we treat with RICE. That's rest, ice, compression, and elevation, along with analgesia as needed. That is the bulk of what you need to know for your test. A grade 3 sprain is a complete ligament tear, while the grade 1 is just overstretching of the muscles with microscopic tears. A grade 2 is an incomplete tear, but the grade 3 is a complete tear. Ligament tears occur from excessive stress across the joint. Common examples would include an ACL, the anterior cruciate ligament, PCL, posterior cruciate ligament. This causes instability of the joint. This is why you have to have the anterior drawer sign, the posterior drawer sign, and the Lachman test down. Remember, the Lachman test is just the anterior drawer at 20 to 30 degrees. With all those signs, you have excessive mobility of the knee depending on the ligament that has been damaged. When you're imaging an injured joint, make sure you remember that a CAT scan is more useful to diagnose bone pathology, whereas the MRI is more useful for the soft tissue injuries. Let's talk about the unhappy triad of the knee. This is where you have a medial directed blow to the lateral side of the knee, resulting in an ACL tear. There will also be a medial collateral ligament tear and a medial meniscus tear. That's the unhappy triad. However, the unhappy triad does not happen that often. More often, you just have an ACL tear and get a lateral meniscus injury, but that doesn't sound as cool as the unhappy triad. Let's move on to meniscal tears. The menisci are crescent-shaped pads of the cartilage located between the femoral condyles and the tibial plateau. Meniscal injuries occur most often from twisting injuries. The presentation will be a patient complaining of vague pain inside the knee joint. They may have clicking or locking of the joint and pain along the joint line near the tear. Patients will often have tenderness along the joint line as well. They also can have loss of smooth, passive motion of the knee. An MRI is going to confirm the diagnosis. NSAIDs are used to treat this, along with physical therapy and arthroscopic repair for debridement. Though recently this has come under major fire and may soon be stopped, a study found that physical therapy alone compared to surgery and physical therapy had equal outcomes. For complications, definitely know that meniscal debridement predisposes the patient to developing osteoarthritis at an early age. Let's go into compartment syndrome. The muscles in the extremities are grouped together in very strong fascial membranes. Acute compartment syndrome develops after a trauma to a limb, usually involving a fracture of a long bone. The trauma causes very high pressure in the soft tissue because of the very strong fascial membranes. That swelling becomes very pathologic. All that pressure results in a decreased blood supply to the muscles, nerves, and everything else distal to that injury. Let's go into some of the signs of compartment syndrome and how we diagnose it. Generally, we think of the P's: pain, pressure, pallor, paresthesia, paralysis, poikilothermia, and pulselessness. Early signs is pain, and everyone who breaks a bone has pain, but this is going to be excessive to what you'd think they'd be. Just the slightest touch causes excruciating pain. The area will also feel very firm, like it's under pressure, and has been described as a wood-like feel. Pallor is actually a pretty uncommon finding, but it can progress from so much swelling that you even get pulselessness. Patients will have diminished sensation or paresthesias, muscle weakness, and this can progress to paralysis. Diagnosis is based on clinical features and measurement of compartment pressures. Labs are not that helpful for the diagnosis, but you can certainly see an elevation in serum creatinine kinase and myoglobinuria. Measured compartment pressure greater than 30 millimeters mercury will indicate a need for a fasciotomy, and that's the primary treatment. It seems brutal and indelicate, but you have to open up that compartment and let that pressure out. Let's move on to the spine and talk about back pain. Back pain can have a very, very large differential diagnosis. Many pathologies can result in back pain, but the pathology may not be located in the spine itself. We'll go through a list of high-yield back pains in a minute, but first let's tackle back pain that's actually coming from the spine. If your back pain is located paraspinally along the muscles on either side of the spine, this would be consistent with muscle strain. This is one of the most common causes of back pain. There should not be any radicular pain or pain traveling down the leg. Conservative therapy with rest and NSAIDs and physical therapy is about all you have to do. Patients should continue with daily activities because staying immobilized will make things worse. Next, let's focus on degenerative disc disease, which can lead to herniation of the disc. The herniation causes nerve impingement, and because you have this nerve impingement, you will get a radiculopathy, like pain radiating down the leg. In the H&P, the patient will say something about pain extending from the nerve root along the path of a compressed nerve. Characteristically, sensory and motor deficits depending on the nerve root involved. Pain worsens with straight leg raises or Valsalva maneuver. With degenerative disc disease, what type of study would you use to make your diagnosis? That's right, you'd want to get your MRI to diagnose this because you want to allow a visualization of the soft tissue. You can see if there's a disc bulging and you can see if the nerve is compressed. So how do we treat this? Oftentimes we start with the same treatment as our muscle strain patients: activity modification, NSAIDs, and physical therapy. Even with disc herniation, we can get patients a great deal of improvement with conservative therapy. However, now we do see more and more conservative therapy failing, and we normally have to move on to corticosteroid epidural injections and even surgery to decompress that nerve. Let's move on to spinal stenosis. This is definitely a highly tested topic. Spinal stenosis is generalized narrowing of the bony spaces of the spine secondary to arthritic changes causing nerve compression. This is most commonly seen in middle-aged and older adults. Definitely know the signs and symptoms of radiating pain that's worse with walking or standing. This is classic for spinal stenosis, especially if they're standing up straight or leaning back. You may want to ask them if their symptoms improve when they go to the grocery store. Why would that make a difference? Sometimes the pain improves when they lean upon the cart as they walk. So they may not be able to walk very well into the grocery store, but they can walk fine for the next few hours because they're bending their spine slightly and relieving that nerve compression by leaning on the cart. Claudication from peripheral artery disease will cause pain in the legs with exertion and then improve with rest, but it doesn't change with position. Imaging is normally a CAT scan or x-rays to confirm the diagnosis. MRI may be helpful to rule out herniation. Treatment is analgesia with NSAIDs, physical therapy, epidural injections, or surgical decompression. The treatment here is the same as degenerative disc disease. You may try to use conservative management, and if that's not working, then surgical management is indicated. Cauda equina syndrome is a definite high-yield topic. Cauda equina is an extension of the dural arachnoid sac beyond the inferior tip of the spinal cord and a complex of terminal nerve roots contained within it. Trauma can damage the nerves running into this sac, and neoplasms can cause compression, but either way, it causes a very unique constellation of symptoms. Symptoms will include severe back pain, urinary retention, change in your bowel habits like complete loss of control, anesthesia in the perineal region, which is called saddle anesthesia due to impairment of the pudendal nerve. Patients will have numbness of the groin, the inner thighs, so basically anything that would touch a saddle if you were sitting on a horse. Decreased rectal tone is also common. You can treat Cauda equina syndrome with immediate surgical decompression because it can quickly result in permanent neurological injury. IV steroids are commonly given to decrease spinal cord inflammation, and radiation is used in the cases of neoplasms. Let's go over some other common causes of back pain. As we've said before, back pain is really common, and sometimes the pathology is in the spine, and sometimes it's often referred to the back. So let's go through a list of scenarios We aren't going to go into any detail here because we're going to cover most of these in other videos. If the pain is worse at rest and gets better with activity, consider ankylosing spondylitis. What is the classic age and gender of someone with ankylosing spondylitis? This is a male in his 20s to 30s, and remember, it gets better with activity. If the patient has pain for 24 hours a day, including night and during rest, think about cancer. Bowel and bladder dysfunction or saddle area anesthesia is associated with cauda equina syndrome. Epigastric pain that radiates to the back is related to eating. Think about peptic ulcer disease or pancreatitis. If you have right upper quadrant pain that radiates to the back and worsens after eating a fatty meal, you should consider cholecystitis or other gallbladder pathology. If there is a pulsatile mass, you should consider abdominal aortic aneurysm. Now let's move on to back pain that radiates down into the pelvis. What type of pain would you consider with this? Think about renal stones. Also think about pyelonephritis if there's CVA tenderness. If you have back pain with osteoporotic patient, think about compression fractures. If you have back asymmetry, that could be scoliosis, but most of the time scoliosis does not result in back pain unless it's quite severe. Back pain with an abnormal gait where the knees stay flexed and the hips remain flexed is due to spondylolisthesis, where there's an anterior slip of the vertebrae, usually at L5 to S1. You can see this on the lateral spine x-ray. And you have systemic symptoms of infection, consider meningitis, discitis, osteomyelitis, or an epidural abscess. Hopefully you guys remember a little about your brachial plexus from step 1. For step 1, you need to be able to label all the nerves, and the good news is that you don't have to do this for step 2. What you do need to know for step 2 are the symptoms of a brachial plexus injury. Knowing the difference in these injuries of the brachial plexus is high yield. We talked about some of the upper extremity nerves in the previous lecture, like ulnar claw and ape hand. Herb du chain palsy is an injury to the superior trunk. Herb du chain palsy is caused by hyperadduction of the arm, causing widening of the humeral glenoid gap. For example, birth or shoulder dystocias. Babies of diabetic mothers tend to be large for the gestational age, and the larger you are, the more likely you are to have a shoulder dystocia, clavicle fracture, and herb du chain palsies. You can also have this in adults if you have someone on a motorcycle and they fall and land on the pavement on their neck. This can cause a herb du chain palsy also. This causes the classic waiter's tip feature, where the arm is extended and adducted with a pronated forearm, like a person is taking a discrete tip. Let's talk about Klumpke palsy. Is an inferior trunk C8 to T1 injury that causes another type of claw hand, where the forearm is supinated and the wrist and the fingers are flexed. You may see atrophy of the thenar and hypothenar eminences. It is also associated with Horner syndrome. Overall, Klumpke is much less common than herb du chain. One mechanism of injury is a patient tries to catch themselves on a tree bench when falling. So you can remember this by the phrase, Klumpke the mumpke hung from a tree. But be careful, this isn't ape hand, which we talked about in the last lecture. Remember, apes are not monkeys. Alright guys, let's go to the end of session quiz. Let's go through the answers. First question. How is compartment syndrome diagnosed? Needle manometry. A needle is attached to the manometer and it is placed into the compartment. There you can directly measure the pressure. How does the pain of spinal stenosis differ from the pain associated with peripheral artery disease? Spinal stenosis is pain in the legs and will often be worse when the patient is standing up straight and will improve when bending over, while peripheral artery disease will get worse with exertion but not really change with position. Next question, what's the cause of the low back pain given the following hints at presentation? Pain that increases with passive straight leg raise, you have to think about a herniated disc. Acute urinary retention with back pain, cauda equina syndrome. Severe back pain that radiates to the groin, renal stone. Pain limited to the paraspinal region is most likely muscular strain. Back pain that improves with activity, think ankylosing spondylitis. You definitely need to make sure you know all of those. That's it for this lecture, guys. See you next time.
Hello, I'm Dr. Mike McInnes with a medical news flash. For years, the O'Donoghue triad, also known as the unhappy triad or the terrible triad, consisted of injury to the ACL, the MCL, and the medial meniscus.
Oh, my ACL, my MCL, my medial meniscus. Oh, it's so terrible. I'm so unhappy. Oh.
But more recent studies show that a little more than half of these so-called O'Donoghue's triad injuries involve the ACL, the MCL, and the lateral meniscus.
Oh, my ACL, my MCL, my lateral meniscus. Oh, it's so terrible. I'm so very unhappy.
And that's your medical news flash.